Okay, thank you. First of all, I'd like to thank Loughborough University and the AIS for inviting me over and for hosting me this week. And for my, I guess, 15-minute or so talk, I want to talk about, well, you can see the title there, Breathe What You Eat, Asthma-Related Issues in Athletes. I want to talk about the relationship potentially between what you eat and asthma, and exercise-induced asthma, okay? A lot of this work I did in my early career to mid-career. I'm doing less of it now, although I come full circle a little bit and doing a little bit more. And I just want to share with you some of the data we produced. So first up, I want to, this kind of tells it all, right? If you can't breathe optimally, you can't perform optimally. Simple as that, okay? And also, exercise-related respiratory symptoms certainly are the most reported medical issues in competitive athletes, okay? And that asthma, or what we call exercise-induced bronchoconstriction, or exercise-induced asthma, same thing, is the most prevalent chronic disease in this group of individuals, in this cohort, okay? Now, what is asthma? So I'm going to give a real, I know they've only got 15 minutes, so I'll keep this brief. What is asthma? What is asthma? Well, it's an inflammatory disorder of the airways, okay? It can be persistent, not persistent. Common symptoms, as you can see, is things like dyspnea, labored breathing, wheezing, cough, chest tightness, excessive mucus or sputum production, okay? The airways are very twitchy. They're very, very hyper-responsive to things like allergens, pollen, dust, air irritants, which could be things like smoke, chlorine in pores, aspirin, lung infection, and of course, exercise, okay? Now, without reading all this through, I've just used the terms exercise-induced asthma and exercise-induced bronchoconstriction. In the literature, those terms are used interchangeably, okay? But they mean pretty much the same thing. It's an airway narrowing that can happen during exercise or commonly following exercise, okay? So we call that a bronchoconstriction, an airway narrowing, okay? All right, now, I'll literally spend a minute on this slide, okay? The pathogenesis of this condition, exercise-induced bronchoconstriction or exercise-induced asthma, is all to do with individuals when they're exercising, obviously breathing in air, okay, and our airways, if you like, warm and humidify that inhaled air before it gets to the alveoli, where gas exchange occurs, okay? And in the process, we get a dehydration occurring in this airway surface liquid there. You can see those little squiggles that are lining the epithelial cells, okay? Now, that's an issue. That's an issue because it dries out the airways. So we have an increased osmolarity of this airway surface liquid, and water is poured, if you like, or moves from airway cells, like mast cells, eosinophils, to try to restore the volume of the airway surface liquid. In the meantime, these cells, if you like, for want of a better word, shrink, and in the process release nasty inflammatory mediators. And these are known as things like leukotrienes, prostaglandins. You've probably all heard of histamine, okay? And they can all, and those guys are nasty and basically result in that airway smooth muscle contracting, okay? Increases capillary permeability, increases airway wall edema, and we get the mucus secretion occurring as well. So all nasty, all resulting, if you like, in airway narrowing, which is obviously bad, okay? Now, how do we diagnose this condition, exercise-induced bronchoconstriction or exercise-induced asthma? Well, the most obvious airway challenge is exercise, okay? Now, what we do is we will measure someone's baseline lung function, and what we're after is what is known as their FEV1, the amount of air that is breathed out in 1 second. And so it's a forced expiratory volume in 1 second, okay? And then we will challenge the airways. It could be an exercise challenge test, okay? It could be what is known as a eucapnic voluntary hyperpnea challenge test, which is a mimic for an exercise challenge. It means that this person does not have to actually exercise, and they're breathing at a rate of around about 30 times their baseline FEV1. So they're doing this, right? They're hyperventilating for 6 minutes at that ventilation rate. You're monitoring that ventilation rate and you're telling them you need to speed up or slow down, okay? That dries out the airways. So for an asthmatic, they don't like it, okay? For someone who doesn't have asthma, it's going to have no effect, okay? So we see a bronchoconstriction occurring. So then we pull them off that, and then we do serial lung function tests again, where after the FEV1, at various time points after that challenge, okay? And in this case, you can see we've gone out 60 minutes, okay? Now, what we tend to see in someone with exercise-induced asthma then is worsening of their lung function. That FEV1 is going to be reduced. So the amount of air they produce in 1 second is going to be lower. And it's usually at its worst around about 15 to 20 minutes after that challenge, whether it's exercise or EVH, okay? And what we're looking for is a 10% drop in FEV1 post-exercise or post-EVH. Okay, so we might see, so here we can see the FEV1 percentage change from baseline. Okay, here we have a serial, in this case, post-exercise lung function test. And you can see that this individual, so for this, say these individuals here, their lung function is worse at around about 15 minutes. Now, we diagnose EIB or EIA, we're looking for a 10% drop. Okay, so there's our minus 10% drop. So mild EIB would be anywhere from probably around about 15% less, so it's mild EIA. For someone with moderate EIB, it's around about 25% drop. And for someone with severe EIB or asthma, it's around 50% drop. You want to avoid those guys if you can in the lab, but we see them. Okay, we see them. Okay.
Try again.
There you go. Just briefly, pharmacological medication or treatment. Okay. Is there any issues with pharmacological treatment? Well, maybe a few. For instance, certain medications, such as what was known as leukotriene modifiers. So we know that these leukotrienes are pro-inflammatory, releasing these inflammatory cells. They cause bronchoconstriction. Well, if you try to block that, that works very well in some individuals. Asthmatic individuals doesn't work very well in other individuals. They provide actually only modest, I'd say modest protection against symptoms. Some beta-2 agonists we have an issue there. If you take them for a long time, you get used to them. Okay, so it doesn't afford a very good protection over the long term. And there's also issues with things like inhaled corticosteroids. If you take them at high doses, then there's a concern about systemic and local side effects. Okay, so what about non-pharmacological management of asthma-related issues in athletes? Okay, well, I'm going to talk about the nutritional approach. Okay, what I'm not going to talk about, if I had an hour, I would, but I don't. I'm not going to talk about the avoidance of asthma and EIB triggers, things like pollen. That's pretty obvious. Don't run, in those conditions. Heat and moisture exchange of face masks, which if you put on, will warm and humidify the air. So for an asthmatic, that would be good. Okay. Pre-exercise high intensity warm-ups are very good for alleviating symptoms of asthma. We've done work on that. And inspiratory muscle training that strengthens the inspiratory muscles. I published a paper about 10 years ago showing that is potentially worthwhile, and we're doing another follow-up study as we speak on that. But I'm going to talk about nutrition. Okay. Now, what I am going to talk about today is just briefly salt, dietary salt, fish oil, omega-3s. I'm not going to talk about beetroot juice. I would if I had time. We're going to start a study very soon. I'm not going to talk about caffeine. Caffeine is a bronchodilator, and there's been some nice studies done on that. We did one, and I haven't got time to talk about antioxidants like vitamin C. And there's been a number of studies that have shown a positive effect for vitamin C. So I'm going to concentrate just on salt and fish oil. Oops. No. Okay, maybe I'm just, there you go. All right. Okay, dietary hypothesis. All I want to say about this is, I would say only over the last few decades, certainly the prevalence of asthma has markedly increased in the Western world, okay? And it's probably a consequence of environmental and lifestyle changes. And it's certainly characterized by an increased consumption of processed and refined foods and a lack of fresh vegetables and fruits, okay? So understanding, if you like, the role of diet in asthma or in EIB certainly could identify a novel, safe, and relatively inexpensive treatment for individuals with this condition, right, compared to pharmacological medication, which is very expensive. So first up, I'm going to talk about dietary salt and the airway response to exercise in asthmatics. This is where I first started. In fact, I built my early career on this guy right here, this dietary factor. Now, in terms of epidemiological evidence for this, I would say in the 1980s, certainly the evidence was anywhere from weak to strong, mostly out of Great Britain, in fact. You can see the titles of those papers there: dietary sodium intake, the risk of airway hyperreactivity in a random adult population, a diet rich in sodium may potentiate asthma. Now, that's kind of got me started getting me to think about this. But then there was a few, not many, a few like interventional studies that were either positive or negative. There they are. Are asthmatics salt sensitive? The effect of alterations of dietary sodium on the severity of asthma in men. These were very, very small interventional studies. And this was actually the last one that came out from Nottingham. Does a low sodium diet improve asthma control? And in terms of salt and exercise-induced asthma, which I was interested in, I would say that obviously the data is much more convincing. There's definitely an association between the degree of bronchoconstriction during and after exercise and the amount of salt, sodium chloride that we eat, okay? And I've just listed some of the papers here, okay? And I just want to briefly talk about this 2005 paper. Well, actually, before that, I will also say that there seems to be a dose response. There seems to be a dose response such that the change in this forced expiratory volume in 1 second, pre to post exercise, is dependent upon the dose. Okay, so we're seeing a worsening of EIB or EIA on a high salt diet compared to a normal salt diet, sodium chloride, compared to a low sodium diet or low salt diet. How am I doing for time? Okay, almost there. Okay, so there's a lot of stuff going on here. Take-home message is, with this particular study, we basically loaded up asthmatics with either a high salt diet or a low salt diet. And how much was that? Well, actually, it's blocked. Sorry. But basically, the low sodium diet, so I'm talking about sodium, was 1,500 milligrams for 2 weeks. The normal sodium diet is what they came into the study on, 3,500 milligrams of sodium. And the high sodium diet, we loaded them up to almost 10,000 milligrams, all right, to see if we get an effect. And then, so we did that for 2 weeks, and then we had a 1 week washout here, crossed them over. So it was a randomized crossover clinical trial. Okay. In a nutshell, what do we see? Well, there's that familiar graph of percentage change in FEV1. Okay. Times post-exercise, we went out to 120 minutes. And there is the high sodium diet. And the one up is I'll use a pointer here. The one up is right there, is the normal sodium diet. And look at this, there's the low sodium diet. Less than that 10% threshold that we use to diagnose EIB. Okay, and also, that's really good. And also we did a lot of measurements in sputum. So it's not very nice for these asthmatics. We get them to hack up sputum. And we can do a lot of little fancy measurements, and we can look at airway cells, inflammatory mediator production, and measure these nasty inflammatory mediators. And they were all down on the low sodium diet compared to the normal sodium diet compared to the high sodium diet. Okay, so very, very good. Okay, omega-3 fatty acids, fish oil. Okay, is there an association between the severity of EIB and airway inflammation? Yes, there is. I'm going to bypass this. We all know about fish oil, just for the sake of time. We all know about fish oil. It's an anti-inflammatory. It's used to treat conditions like rheumatoid arthritis, inflammatory bowel disease, cardiovascular disease. It has been used in asthma. Again, I was interested in the exercise-induced asthma studies, and here they are. Here they are. There's just 3 of them. All positive. All positive. Some more right here. And there were a few negatives as well. There's 4 studies here. I don't have time to pick these apart. They were flawed as far as I'm concerned. Yeah. So just briefly, one of the first papers we published on fish oil supplementation and its role in exercise-induced bronchoconstriction was in Olympic caliber athletes. Okay, and basically we loaded these athletes up for 3 weeks on 3.2 grams of EPA, which is one of the omega-3s, omega-3 fatty acids found in fish oil, and 2.2 grams of DHA for 3 weeks. Then, just like this salt study, we had a washout period. I think it was 2 weeks if my memory serves, and then we crossed them over. That's because there was a placebo group as well. Okay, and again, just like the salt study, look at this. There's that 10% threshold. So here's the minutes after exercise. Here's the percent change in FEV1. Okay, this would be the placebo, I think, normal diet. And look at it. There's the fish oil diet right here. That was a -3% drop. -3% drop. Remember, these are the same subjects. These are the same subjects. Up here, these are the controls. There's no effect on the controls. Okay, so with a non-asthmatic. And again, so we saw an 80% improvement in lung function post-exercise. 80%. Okay, and a 20% reduction in bronchodilators. And also, just like the salt study, we measured inflammatory mediators in the airways, and they were all down on the fish oil compared with the placebo and normal diet. Okay, 3 minutes. Okay, and we did another similar study in just recreational athletes and saw a similar story, improvement in lung function. I'm going to actually leave that study there because one of the questions we always had was, well, how does fish oil compare to pharmacological medication? And can you add them? Would you get even a more benefit? Well, this study, we did that. We actually compared fish oil against montelukast or Singulair, which is a leukotriene blocker that blocks leukotrienes that causes bronchoconstriction, and then we added them. In a nutshell, so that's the normal diet, if you like. We did this for 3 weeks, and so the fish oil was very effective again in improving lung function. The Singulair was just as good, and when you combine them, it conferred no additional benefit. Okay, but the good thing was fish oil was as effective as pharmacological medication. Okay, and then lastly, this was a study that came out in 2017 from just up the road, Nottingham Trent University, that took all my work and said, okay, how about if we half the dose? How about if we half the dose? So they halved my dose of 6.2 grams a day to 3.1 grams a day. And what did they see? Well, what they showed was the 3.1 grams a day was just as effective as the 6.2 grams a day, but both were effective in attenuating that bronchoconstriction. There was an improvement in lung function. Okay. And my last slide, where I finish here, is I've got a table over here with a summary of dietary strategies to manage exercise-induced bronchoconstriction. I would say in terms of the evidence level, So dietary salt restriction is good. It's good. It should be implemented. What about fish oil? I'd say it's good. In terms of antioxidant supplementation, vitamin C, I'd say is medium. We probably still need a little bit more work done on that, but I'd say it's medium. Things like beta carotene, lycopene, vitamin E and C and E is insufficient. Not enough work has been done on that. Caffeine is good. It's a bronchodilator. It works. It tends to work. Okay. Prebiotics. There was one study that's been done out of Nottingham Trent University showing a positive effect on the IV. And the last one, coming back to that beetroot juice, is we're going to try this coming up starting in about 2 weeks. Okay, it's an anti-inflammatory, it's an antioxidant. Let's give it a shot. Basically, load these up only up on 1 week. 1 week of beetroot juice. Okay, let's see what we got. Yet to be tested. So, in a nutshell, yeah, I mean, this tells it all right. A food-based approach that is accepted and tolerated is a preferable way to ensure long-term nutrient intake. So, it's certainly, medical practitioners should pay attention, right, to their asthma or EIA patients and what they eat. That's really, really important. To incorporate dietary assessment and nutritional counseling in their everyday practice. Early on, they were fairly resistant to this, okay? Certainly in Bloomington, where I work, and Indianapolis, we pretty much, sold this to the medical practitioners to look at this. And we're not talking about replacing pharmacological medication. What we're saying is actually it should be incorporated right into their management plan, okay? So with that, thanks very much.